be hearing from 3 different healthcare technology companies. And the common theme for all of these is all of these companies we're going to be hearing from are using innovative technologies in various settings to help address clinical problems. First today we're going to hear from CareNSync, which offers a mobile platform that allows care teams to collaborate on patient transition plans to expedite discharges and reduce readmissions. And then we're going to hear from Asthmopolis, which makes a sensor that tracks asthma symptoms and inhaler usage, and a mobile app that provides tailored information to patients and providers in an effort to better manage asthma. And finally, we're going to hear from Direct Dermatology, a telemedicine company that provides remote dermatology consultations, expanding access to specialty care. And we're joined today by Shiva Subramanian, who's the CEO of CareNSync, Diane Kay, the Senior Vice President of Business Development from Asthmopolis, and Raj Gupta, the Chief Medical Officer at Direct Dermatology. So before we begin, just a couple of housekeeping items. First, folks should see a little polling questions at the bottom of their screen. If people are willing to fill that out, it just gives us a better sense of who's on the call and who our audience is, so that would be very helpful. The session, and also at the end of the webinar, we're also going to be asking for feedback on the webinar via a very brief question survey. So if people would be willing to fill that out as well, that would be very useful. Today's webinar will be recorded. The slides and the reports will be posted on the website within a week. You can see the website listed up on the slides above. For questions, we're going to be hearing from 3 presentations today, so we're going to have a lot of content, but we are going to save some time, about 15 minutes to the end, for any Q&A. And if people have questions during the presentations, you can also send the questions via your chat box to the presenters. I know at least Shiva might not be with us at the end of the presentation, so if you have any burning questions for Shiva from CareNSync, you might want to send it during his actual presentation. He'll be starting today. But again, you can use the chat box to ask any questions. If you have logistical questions, you can just send them to the host. And if you have questions about the presentation, you can send them to all participants so that other people can see what's being asked. So today's speakers, first we're going to hear from Shiva Subramanian, the CEO and founder of CareNSync. Shiva has 18 years of experience in the communications technology industry, and before starting CareNSync, he was the director of product management for Nortel Avaya Healthcare Solutions, where he led the formation of a business unit delivering communication solutions for hospitals. And as a consultant for the Society of Hospital Medicine, Shiva offered Project Boost, the ROI on reducing readmissions for Project Boost, a nationwide project addressing care transitions. He also trained in other interventions such as the Care Transition Intervention and Project Red. Next up, we're going to hear from Diane Kay, who is the Senior VP of Business Development for Asthmopolis, where she focuses on developing new business and business relationships for the company. Prior to her role at Asthmopolis, Diane worked as an independent consultant where she advised clients on their overall business strategy and model. Prior to that, Diane held several leadership roles at Athena Health over 10 years, including product development and management, operations, professional services, and strategic development. And has additional experience as a management consultant and as a director with Blue Cross and Blue Shield. And then finally today we're going to hear from Raj Gupta, the medical director, chief medical officer at Direct Dermatology, and also a practicing dermatologist in Northern California. He completed his dermatology residency at Stanford University Hospital and Clinics and is board certified by the American Board of Dermatology. He did his internship at the Mayo Clinic in Jacksonville and has MD and PhD degrees from Vanderbilt University School of Medicine. And he's also the adjunct clinical assistant professor of dermatology at Stanford University School of Medicine. So with that, I will hand over to Shiva from CareNSync to start his presentation.
Hello, Lori. Can you hear me?
Yeah, I should have just pressed.
Okay, very good.
Oh, great.
Very good. Thank you. Thanks, Lori, and thanks to the California Healthcare Foundation and the California Improvement Network for this opportunity, and thanks everyone for joining this session. So we are CareSync, and as our name suggests, our goal is to bring providers of care, hospitals and post-discharge providers of care in sync around what needs to be done to transition a patient safely from the hospital to outside, or even inside departments or services within the hospital. And in doing so, we enable better care at lower costs for the entire healthcare system. Quick intro to our founders. My background, as you've already heard about. Our two other co-founders are Dr. Aladdin, who's the Director of Quality Improvement at the Palo Alto VA, and she's a published expert in readmissions risk factors as well as discharge process improvement. And our technology co-founder, Sati Tari, who heads the VP of software development for us. And our investors with whose support we are operating includes California Healthcare Foundation, HealthTech Capital, as well as Hearst Business Media, which is a healthcare and other media content company. So everyone, I think, should be knowing about the challenging times hospitals are facing today and the pressure they are under to improve care and reduce costs. With readmissions penalties kicking in last October, reducing Medicare margins and the impending payment shifts that are moving from volume to quality, they're paying closer attention to how they can improve their readmission rates, their quality measures, as well as improve efficiency in terms of how well and efficiently they take care of patients as they move through their system. The fundamental problem they face in solving this, better improving quality while reducing care is one of, poor care coordination. It's been studied in depth, and there was a Joint Commission study that said that 66% of the medical errors in this area are caused due to poor communications or communications failure. A lot of this has to do with the number of people taking care of a patient. Research shows that even within a short 4-day stay, there are more than 30 to 40 providers that touch the patient in the inpatient setting itself, let alone the outpatient providers that need to care for them after discharge. And most of the time, the rest of the team is not known to any given team member, which prevents information from being shared in a timely and an efficient manner. And this dropped information or delayed information can cost the hospital inefficiency and also create patient safety issues if not addressed. When we looked at this problem of readmissions, it was clear that there's been a lot of research and evidence that shows what type of interventions could improve this care transition process and reduce readmissions. But all of them were very narrowly constructed trials. In a real-world setting, what we found was the hospitals required a very flexible system that would enable collaborative care by taking a mix of various different types of evidence-based interventions, monitor those as the process is implemented for process measure improvements, and then iterate that over time so that they can practice continuous quality improvement. And that's what we saw was missing, which we decided to address through a mobile and web-based care collaboration platform, and which is what you see on your screen. So what our software allows the team to do is to form patient-centered teams, both consisting of inpatient and outpatient providers that come together around the patient, share information regarding risk factors that may impact discharge, barriers to discharge, and our software automatically stratifies those patients into low, medium, high risk and identifies evidence-based interventions that have been shown to improve the transition process and reduce likelihood of readmissions. And it tailors those interventions specific to each patient and dispatches them to the relevant interdisciplinary team so that they can perform those interventions in a very timely manner and make sure that this patient is discharged in a safe and a timely way and is reduced the risk of readmissions. As an example, you see where high-risk patients, there may be an intervention requiring patients to be visited at home, follow-up calls for medium-risk patients, which our system automates, and teach back for all patients, including the low-risk patients, which is what is depicted on the screen, so that the hospital and health systems and providers can construct their own best-in-class discharge process for their patient mix using our system, deploy this process, monitor it, and then see how the interventions are effective and iterate on over time. In doing so, we deliver safer care for the patients, more efficient care for the hospital and health system, and we have an ROI model that provides tangible returns within 6 to 9 months, which comprises of penalty avoidance, elimination of unreimbursable Medicare and Medicaid costs, as well as efficiency improvements through patient flow improvement across the system. We did a pilot in Marin General Hospital located here in the North Bay a year ago, and in the 60-day pilot, they saw such impressive results in adoption and improvement in process measures that they purchased the software and have deployed it throughout their hospital. So all patients that are being discharged from Marin are being discharged through our system with a mix of process interventions from Project Boost, Project Red, and the Coleman model applied to high-risk patients only. And our software is being used to tie all of these interventions together and across almost 500 trained clinical staff using the software at various points to discharge and transition patients both in and out of the hospital. Very briefly, I'll present 3 process measure improvements that we've seen within the 60 days that we've been live at the hospital. And in another month or so, we expect to capture some outcome measures. And in a future webinar, we may be able to share that with you as well. What we saw at Marin General is actually the same thing we're seeing at other places as well, that before we deployed our software, there was not an easy and effective way to determine who's on the team for a given patient. And that caused a lot of confusion. With our software implemented, more than 72% of the patients had 4 or more members joining the team and collaborating through our software on these interventions. So care team effectiveness and communication effectiveness went up significantly, and this actually saved the provider's time rather than chasing information and paging and waiting for responses. Another thing that improved significantly is the number of communication points and coordination of care points that happened through our software, which included both messages and automatic alerts that our software would send out. And there have been 650 patients in this period that have gone through our system, and more than 10,000 care coordination points have been, messages have been exchanged across this number of multidisciplinary teams. And then the last measure that I'll share with you is that one of the big challenges that the hospital faced was identifying what interventions need to be done for which patients, and it was very difficult for the team to share who is a high-risk patient and who is not. So our system solved this by automatically classifying risk for patients, identified 8% of the patients into a high-risk category that were placed into a post-discharge coaching program, and applied other interventions to the 45% of medium-risk patients that got a very risk-specific discharge plan identified through our software. The remaining patients got the basic fundamental improved Project Red process applied to them. So the team is really excited about these process improvements. Staff satisfaction has gone up significantly, and the initial HCAP scores that are seeing from patients are also showing an upward trend, which we'll be presenting at a subsequent webinar. But we're excited about this, and we are working with the next couple of hospitals at this point to deploy the software to their sites as well. That's it from me. So if there are any questions, I will take them now, or if there's no time, then you can email me for any other questions. No questions?
Hi, Shiva, this is Lori.
What about the impact on workflow when a care team uses your coordination solution, both the positive and the negative?
I'm sorry. What was the
impact on workflow? Impact on workflow.
Okay, very good question. So one of the concerns that a lot of hospitals, including Marin, had was whether this would adversely impact the workflow of the providers, and whether they would need to do more things in their shift and spend more time doing things that they would otherwise not benefit from. They were all pleasantly surprised that because our tool allows access to the team anywhere, because it's a mobile tool and they're using it over iPads and iPod touches and iPhones across their system, they found that their workflow actually simplified so that they wouldn't need to go back to the nursing station to find someone or to page multiple people to find information, and certain capabilities such as the automatic date of discharge, pending discharge notifications, automatic notifications to aftercare providers about a patient being prepared for discharge or patient being admitted to the hospital. All of them, they saved a significant amount of time for the providers who otherwise would either not get this information or would need to go through hoops to find this out. So I would say it positively impacted the workflow. I see another question from Doug Nagel. So the question is, can you describe your discussion approval with Marin's IT, security, and HIPAA department? So, initially the people we worked with were the quality improvement and medical director at the hospital. Once we got the nod from them that this would satisfy their needs, clinical needs, the next discussions were with the CMIO and the CMIO and the CIO of Marin General, and they had a security questionnaire that we provided because our software is implemented in a HIPAA compliant manner. We shared those data points and features that support encryption and transport, encryption at the storage, as well as a thin client that wipes the device clean when the user logs out. So they were satisfied with the HIPAA compliancy features, which then allowed us to move forward to do a pilot and implementation.
Great, thanks, Shiva. This is Lori. There's one more question that came in. Is this program synced with EMRs for EHRs?
Yes. For a minimum implementation, we require an ADT feed coming out of the EMR or their ADT system, the admit, discharge, transfer system, so we know what patients are in which place in the hospital. We provide at a minimum, a write back of a PDF of all the interventions that have been administered for a given patient that can be put into the EMR at the time of discharge. And then we also support other optional interfaces that we have an HL7 interface engine that we can use to write adapters for instance, bringing in order management feeds from the electronic medical record. And for the record, the Marin uses a McKesson Paragon electronic medical record.
Great, thanks, Shiva. Great questions, and I think we'll hand over now to Diane. Shiva, if you don't mind passing the ball over to Diane, we'll hear about Asthmopolis.
Okay, I'm just doing that right now. Thank you, everyone. Appreciate the time and the questions.
Okay, well, good afternoon, everybody. To the California Healthcare Foundation, thanks for inviting us to participate, and thanks for all of the attendees who are joining us this afternoon. I'm going to get right into this, talk to you a little bit about Asthmopolis. In terms of our agenda today, I thought I'd focus a little bit on the problem we're addressing. We'll spend most of our time on asthma today, though we are also focusing on COPD. Talk a little bit about our approach, talk about some of the results in our early programs that are fielded right now, and just give a sense of why we believe this is working for our clients. And I welcome all questions throughout the presentation or at the end. As many of you know, asthma is is growing in terms of prevalence. In 2010, when the business was incorporated, the asthma prevalence nationally was about 7.7% of the population. And in 2012, it had risen to 8.4%, or 25 million people with asthma in the U.S. today. About more than 60% of those who are diagnosed with asthma are actually walking around with uncontrolled asthma. And despite the fact that they're uncontrolled, about 88% of these folks are saying that they're doing okay. So one of the things we have an issue around is the lack of understanding, even among people with asthma, that they could be doing better, that many of their symptoms could be relieved, they could experience fewer exacerbations, better quality of life, and fewer lower utilization trips to the ED and inpatient admissions. This results in about a $50 billion price tag, much of which we think is really preventable and avoidable. And this uncontrolled asthma drives costs. People with uncontrolled asthma about 3.5 times more likely to visit an ED in any given year. And uncontrolled patients are generally costing about $3,000 to $4,000 more per year in the system, based on some nationally available data, as well as data that we have from our clients. And again, our position is that this is all avoidable costs, avoidable utilization, and that's what we're really focused on, improving asthma control to both improve quality of life and reduce unnecessary utilization. And with that, we're trying to close the spending gap. We target our approach towards patients and their clinical teams that we think most benefit from what we're doing. Our goal is to reduce the very high costs associated with those who are typically not adhering to their asthma management plans. We seek to improve control overall, and we expect and hope to improve quality of life as measured by national quality measures. In terms of our solution, it is a combination of the items that you see on this page. We are an FDA-regulated and cleared offering. So what you see on the left-hand side of the slide is actually a standard inhaler, and on the top of it you see our sensor sitting on top. The sensor actually attaches very easily. We have adapter caps for the 2 sizes of MDI inhalers that exist today, and we can attach it both to rescue medications and for those controller medications that are delivered via an MDI inhaler to controller medications as well. The sensor is activated every time someone presses to inhale and use their medication, and the sensor essentially tracks the time and date and number of presses or puffs that the patient used. These data are stored in the sensor itself, and when the sensor comes in contact with the device that it's paired with, it will send that data through the paired device, which I'll speak about in a moment, to our servers. In terms of that pairing and sending of data, we do work with the Qualcomm 2Net hub, so that can be plugged into a patient's home, and then the sensor comes automatically paired, and every time the sensor is in contact or in the proximity of that 2Net hub, the data will transfer. Or even better is when someone has a smartphone, an Android phone or an iPhone, we pair the sensor via the smartphone, and what this enables us to do is not only transmit that data to our servers, but leveraging the GPS inside the smartphone, we pick up the location of the event, which is a very important indicator for folks with asthma. Where are they using their rescue inhaler? So not only time of day, date, but also the location. Was it a work location? Was it something in their sort of school environment, et cetera? So important to note where that use of medication occurred. We then take the data and leverage national guidelines in order to provide information back to patients via a website, via the mobile phone, in order to provide them really trended information about what's going on with they and their asthma in order to create insights, guidance, and tips on how they may improve what they're doing and how they may improve control of their asthma. In terms of tracking controller adherence, we do track when people are using their controller medications. We do capture and enable patients to input their asthma plan so that we know if someone's missed a dose of their medication and can remind them via text or via email, you seem to have missed a dose, Mrs. Smith, today, but it also enables us to track adherence to controller medications. And then the combination of use of rescue medications as well as adherence to controller medication often gives patients great insight about what's going on with them. And they can enter triggers triggers and symptoms to better also enable us to provide more insight on what's really triggering their asthma and what they can do to improve that. This same data is available to care teams and providers so that providers and care teams in clinical settings or in health plans, case managers, can have a much more accurate view of patients, how well they're in control, whether they're adhering to medications, how many exacerbations they're having, when they're having those exacerbations, in order to provide objective data in an environment where often data has been provided based on patient recall, which we all know can be flawed. I should note also that all our applications are available in both English and Spanish, and we do deliver to many folks today completely and entirely in Spanish. This is a view of the provider dashboard. Again, providers or their care teams can look and really understand how their patients are doing in terms of asthma control, adherence, and engagement in their process of care. And this data can be really organized to provide a sense of which patients are doing better or worse with one quick glance. We also have the ability for both patients and providers to provide automated notifications. So if a provider organization, for example, only wants to know about patients who have moved from, let's say, not very well controlled to poorly controlled, or if they've missed a number of doses of medication and would like to engage with that patient, we can provide easy text, emails, or phone calls to provider offices to suggest Mrs. Smith today is out of control, has moved from one stage to the other. And our goal really is to did I miss my EMR slide? It might be coming, but we are working on EMR integration. We're in the process now of integrating with Epic, which will be our first integration. And then we'll engage with others as our clients request integration with EMRs. Our goal is really to support populations with asthma and supportive clinical teams. We consistently monitor patients on behalf of physicians and care teams, or in the case of a payer, a case management team, or a pharmacy team. We provide that first tier level of advice and guidance. Much of that is automated, meeting the patient where they need, for those that like mobile apps and want their information through a mobile app, for those who like email, for those who want to be on the web, and for those who really need or prefer an old-fashioned phone call. We have that capability as well. And our goal is really to provide that in advance of a patient needing any clinical intervention. But again, we do have the ability to alert clinical teams of patients that may require that intervention, and those alerts are based on thresholds that are set by those provider organizations. So the provider organizations decide who they want to see and based on what criteria. And as we design programs, we design the programs to fit into the client's operational processes. Again, that could be a health plan or a provider organization. We always identify a client lead. We have co-branded marketing materials that we provide to patients to educate them about the programs. We could collaboratively define a process for identifying who might be a good target for the program and educating patients. We support all the patient enrollments and provide the ongoing technical support for patient care teams and providers. And we offer continuously monitoring reporting to our clients so that we can always be up to date and providing information about the progress that we're making with patients.
Diane, do we still have you? I think we may have lost one of our speakers. Why don't we go ahead, and I think we might have lost our speaker for Diane. So why don't we, Raj, if you're there, why don't we pass it over to you and we can get going.
Apologies for that. I must have been disconnected.
Ah, there we go. Great.
Should I just continue? I'm so sorry.
Sorry. No, that's great, Diane. We were. Go ahead. Why don't you finish up? That's great. Thanks for calling back in.
Okay. So apologize for that. Don't know what happened. So let me move on. Just in terms of a little bit more background about the business, we did receive our FDA 510 clearance in July of last year. We really focus on providing services to organizations with aligned clinical and economic incentives. That may be payers, that may be ACOs, that may be provider organization, medical groups, all of which are our customers today. This is really just a sense of our customers. And we have about 5 programs that are rolling out or been rolled out in California, Florida, Brooklyn, New York, and are looking at 2 others, one in Newport News, Virginia, and also a couple of additional ones in California in terms of our progress. To give you a sense of our early results, we have a large program going on with Dignity Health in Northern California, where we've enrolled about 450 patients. Half of those patients, this is a clinical study that was started before we received our FDA clearance. About half those patients are enrolled in a control group, and the other half are in an intervention group. The control group has a sensor on top of their inhalers, but those patients are receiving no feedback, no insight about what's going on with their asthma, neither are their clinicians. And the intervention group receives all the feedback available in our system, and their clinicians are also informed about the progress of their patients. As part of this, the California Healthcare Foundation is subsidizing a randomized control is subsidizing an economic evaluation of this study. So in addition to looking to improvements in control, we'll translate all of that into how that affects utilization downstream. You'll see in the chart to the bottom right our preliminary results. This is really a weeks in study, so we're showing a snapshot of the first 16 weeks of patients in the study. You'll see in red the control group, the line, and the bottom line is those in blue are the people who are in the intervention group. You'll see at the top of the chart, patients start out about at the same level in terms of the average number of inhaler events per week. This is the number of times they're using a rescue inhaler per week. And you'll see declines in both the intervention group and the control group. The reason for, we believe, for the decline in both the intervention and control groups is many of these people are being enrolled after a discharge event because of their asthma, and therefore they're naturally likely to be sort of improving after that discharge event. But additionally, we think there's a bit of a Hawthorne effect going on, that people know they're being monitored initially in some way because they have a sensor attached to their inhaler. But you'll see as we get out longer in terms of 16 weeks, that there's a gap that really begins to emerge, and the control group tends to sort of go back to previous patterns, while the improvements that are achieved in the intervention group continue to be maintained. And you'll see fairly rapidly is that as we intervene, the number of events does go down pretty dramatically. And so what we have are demonstrating both in these and the other studies, that this is not a long-term impact, that we expect to see changes in terms of asthma control, probably within the 3 to 4 month time frame of being in the program. An additional program that we can share some early results, this is a program that's in Louisville, Kentucky. This is a program that's a collaboration of among the city of Louisville, Norton Healthcare, a series of employers, and also one health plan. This is actually a public health study. The city of Louisville apparently has an asthma problem, higher prevalence than in many other cities in the country, and the mayor and the city is really seeking to address this via public health. So one of the things that we do is collect location of events, and from a public health perspective, the city is seeking to understand where there are events and whether there's anything that can be done from a public health perspective. And certainly the employers and payers involved are seeking to look at how asthma control is improved and how that relates to downstream utilization in the first 3 to 4 months. What you can see here is in the bottom right in terms of the chart. This is not this program, which has about 400 city residents that are enrolled via Walgreens. As folks walk in to renew their prescriptions or pick up their medications, they're asked and invited to participate in the program. The control period is actually the first month where the patient has sensors on their medications but are provided no information or guidance back. And then after 1 month, we start the intervention period where all the advice and guidance, feedback to patients is turned on, and you can see fairly rapidly the improvement, the reduction in those who are poorly controlled and very poorly controlled, and those who have improved control with their in terms of their asthma. So why we think this is working and why it works very rapidly, we sort of summarized it in 3 points. First of all, patients don't need to change any types of behavior or daily routines to effectively participate. Once they have a sensor on their medication, which is really easy to snap on, they can go about their business. There's nothing they need to remember to do, nothing they need to remember to measure, no active participation from the patient. We collect data passively. We believe engagement with the system persists because we make it very easy for the patients and their clinical teams to be successful. We consider ourselves a service company, and therefore we're monitoring engagement, understanding what's interesting to the patients, and really trying to make information simple, straightforward, clean, clear, lots of pictures, lots of trend information. And we push lots of information to people in the way they want it to make it easy for them to glean information and get big ahas. And our ability to predict deterioration. We look for patterns and uses of medication so that we can begin to understand which patients are likely to be declining and what's likely to happen to their utilization, so we can intervene either with messaging or a phone call from a nurse educator, or by getting the provider involved in their care before patients have a serious decline. So really with that, those are really my comments, and if anyone has questions, I'd love to take questions.
Great, thanks, Diane. If folks don't have questions now, we can also save some for the end. And I don't see any questions coming through yet, but we also have some time at the end. So maybe we can hand it over to Raj from Direct ERM to hear his presentation.
Sure, I'll do that right now.
Great, thank you. And thanks for all the attendees for the opportunity to talk about the company, Direct Dermatology. And again, I'm Raj Gupta, one of the co-founders and the Chief Medical Officer. So why did we start Direct Dermatology? It was started by myself and a couple of residents from Stanford University. As residents, we used to travel out to underserved parts of California and realized that there was a huge delay in the diagnosis and treatment of skin disease, primarily because there was a lack of access to specialists. There's a national shortage of dermatologists, and this is most acutely felt in rural parts of the country, including rural California. So our two big reasons were to avoid unnecessary delays in diagnosis and treatment and avoid patient morbidity and mortality. So what do we offer? We're a teledermatology consultative service that combines a HIPAA-compliant web-based platform that we provide to clinics, referring providers, and a group of U.S. board-certified dermatologists. Dermatology is a very visual-based specialty and is particularly amenable to delivery of care remotely. So as everyone realizes, the big healthcare challenges include timely access to specialists and care in general, high-quality care, and lower cost of care. So we believe telemedicine for dermatology addresses all three of these big issues that, as healthcare providers, are challenges that we face. And as a resource for primary care clinics, the ability to access remotely a dermatologist to help their patients dramatically reduces wait times, can prevent unnecessary ER visits, unnecessary repeat primary care visits, dramatically limits the amount of in-person dermatology referrals that are required, decreases travel time and costs for the patient, and ultimately can increase quality of care. So we currently have 12 dermatologists as part of our Direct Dermatology, and a lot of them are trained at top U.S. dermatology residency programs and are affiliated with academic institutions. And we're very much a medical dermatology-based group of dermatologists and committed to serving underserved parts of California. So since launching about 2 years ago, we've done over 4,000 consultations, had contracts with a number of different health plans, rural hospital systems, and federally qualified health clinics throughout California. And we have been fortunate to receive strong financial support from the California Healthcare Foundation, and we're now expanding our services throughout California and a number of other states as well. So how our service works, it's very simple. The startup costs are minimal. The referring clinic or provider just needs an internet connection and a camera. So the provider logs in, enters a brief medical history, takes and uploads the picture, and then within 2 business days, we'll receive a report back with the diagnosis and treatment plan. This is a physician assistant near Fresno we work with a lot, examining a patient. He has a medical assistant who's quickly helping him fill out the history and takes a picture of the relevant dermatologic lesion, uploads it on our website, and within 2 business days, he gives back a detailed report. We provide detailed treatment guidelines, what to prescribe, how much of it's prescribed, and patient education guidelines as well. Just some clinical case examples. This is from a clinic, a pediatric clinic near Stockton, California. Before we engaged with this clinic, the wait times to see community dermatologists was about 150 days. This is a patient we saw, an 11-year-old female who had this melanocytic lesion on her scalp. Our direct dermatologist was able to look at this the same day that the case was sent, very worried about it given its features, and arranged to have this excised within the week. And that came back as a pre-melanoma, or what we call a melanoma in situ. So if she had to wait 150 days to have this even examined by the community dermatologist, you can see the potential for how much telemedicine can improve quality of care through early detection of potentially lethal skin cancers. This is another case of a teenager who lives near Fresno. She had 8 different primary care visits and a total of 10 different prescriptions for the severe rash that she had been battling for over 6 months. And once we engaged with this clinic, one of our dermatologists was able to make the correct diagnosis, get on a good treatment regimen, and within 2 weeks there was complete resolution. So suffering for 6 months with this, with telemedicine and engagement with direct dermatology, this resolved within 2 weeks. Another example of a pigmented lesion on a child. Again, and this is the 150 days is the approximate average wait time in large parts of the country to see a community dermatologist. We were able to see this patient again within 1 day. Again, concerning. It was facilitated removal. It did come back as melanoma. We got this patient in to have excision and a sentinel lymph node biopsy done at UCSF within 2 months. Fortunately, his lymph nodes were negative, and so this is likely curative for this patient. And finally, last case example, this patient had had a severe rash for 3 different primary care visits over 3 months, a couple of different prescriptions, no improvement. We were able to recognize this, one of our dermatologists, as a unique type of drug eruption, and got on, stopped the medicine that she was on, got on a treatment plan, and again had significant resolution in 2 months. So we've been closely trying to track how effective our services been for the primary care providers that we work with. You can see that about 50% of the time we're agreeing with the referring provider in terms of the diagnosis. So a lot of times we're changing, changing the diagnosis and altering the recommended treatment plan. And part of what we're trying to do is educate our referring providers on what we recommend as treatment plans for simple skin conditions. We're often recommending a prescription treatment, and on follow-up, there's often improvement after we've seen the patient. A lot of a big question that some people ask is how often are we having to recommend a live visit? So, it's really about, in our data so far, it's about 10% of the time we're recommending a live visit. So we can help manage the patient remotely 9 out of every 10 cases that we see, and that fits with some published studies in the academic dermatology community. So we've been fortunate to receive support from the California Healthcare Foundation. Have engaged a lot of different insurance plans and hospital systems within California, and I'd be happy to address any questions now, or feel free to call or email me if anyone has any questions.
Great. Thanks, Raj. We do have one question that came in for you regarding the referral process. How long does it typically take for the medical assistant or the physician assistant or the physician, whoever's sending the case over, how long does it typically take them to send a case to you all at DirectERM?
So on average, and we've closely looked at this, on average it takes about 5 to 7 minutes to get the medical information, take the picture, upload it, and submit the case. So we really try to work carefully at it so it's not disrupting the flow of the clinic, because everyone's really busy, and that was a big concern that we had when we started this whole process.
Great, thanks. Diane, if you're still there, we have a couple of questions that came in for you. Do we still have you?
Yes, I'm.
Great. First question is the study design for asthma that you referenced. Make sure I have the question here. It didn't randomize. Do you have any concerns for the data that it was just a time trend?
The study for the Dignity Health study?
Yes.
It is randomized. So people are randomized into the control or the intervention group. So it's not a decision that's made a priori. Physicians and providers are selecting people into the study, and then they're randomly assigned either to the control or the intervention group.
Okay, great. Thanks. And I think you mentioned this, another question for you at the beginning. What other respiratory diseases can this solution be used for? Can you talk a little bit about that?
Sure. Right now we started in asthma. Our CEO has a background. He's an asthma epidemiologist and has spent a lot of time focusing on asthma, which is the origins of our business. But as we've gotten started, lots of people have asked us around about COPD, since people with COPD use the same rescue medications and inhalers that folks with asthma do. So right now we're in product development for COPD, and essentially the product will work a little bit differently, though it's still in development. And in that case, what we're looking for, and we have one trial going on with the Veterans Administration in Puget Sound in the Northwest. What we're doing is really looking for the patterns of use of rescue medications and rescue inhalers in order to create an ability to predict deterioration of lung function in those people with COPD. There's usually a prodromal period where people are deteriorating, and that if we can help identify that period, we can sort of seek and provide information and insight to providers in order to enable intervention in advance of someone winding up in an ED or needing an inpatient admission.
Great, thanks. And Diane, just a clarification on the first question I asked you about the randomization. It was actually the Walgreens dispense study that that was being asked about.
Yes, I'm sorry. So it was about the Louisville study where, folks are being enrolled. There may be a bias about who chooses to enroll. That is correct, but it's being offered to anybody who lives in the city. We're available right now, the sensor, in 22 Walgreens, and it's just being offered to anybody who walks in. So there could be some selection bias in that program.
Okay, great. We have another question for you, Dan, about your outreach process and how you decide who to outreach to. Just given the symptoms of asthma and its features, how do you approach that process?
Sure. We work very closely with our clients to identify who would most benefit from the program. Essentially what we believe is about 80% of folks with asthma will benefit. So those who have mild asthma, exercise-induced asthma, we would probably be overkill for. So if you have mild asthma, we suggest that you're probably not a great participant for us because it would be money invested without a great return. Everybody else we think is a good candidate for participation. Oftentimes we have clients who say, well, let's look at those who are high utilizers, who've been in the ED in the past year, who've been admitted, and those are often good candidates, but we also like to note that oftentimes, past utilization is not always predictive of future utilization, and therefore we sort of look for folks, a broad set of folks who either have moderate or severe asthma, and we often use, NCQA definitions to define either moderately persistent asthma or more severe asthma. And then we collaborate in terms of those patients and what the goals are of the provider organization to identify patients who would be well selected for the program, and the same is true of payers.
Great, thanks. Thanks, Diane. Shifting gears a little bit, we have a couple questions that came in for you, Raj. First one is, any difference between this service and services like Telederm? Can you speak a little bit to any differences?
Between our service and Telederm?
Or just other services, commercial-oriented services such as Telederm?
Sure. Well, I think one of our big goals is to, we contract a lot with, dermatology, telemedicine in general, and teledermatology has variable insurance coverage. So we've made a big effort to get contracts to show the value proposition to a lot of different insurance plans and are able to get coverage. And so our goal has always been to try to limit the amount of financial support that a particular rural hospital clinic or federally qualified clinic has to invest to start the program. I think that was one of the reasons why teledermatology has been around for a while, but it hasn't always gotten off the ground because there was always a big commitment that the clinic had to make. So we've tried to make it as simple as possible. The support, the startup cost for the clinic is a camera and an internet connection. That's it. We provide the platform. It's a web-based platform. All clinics, they don't have to pay for that. It's an investment that we've made, and we'll provide any kind of on-site training or remote training that's necessary. So I think one thing that differentiates us is we really try to limit what kind of investment the clinics have to make because we realize they're under so much financial burden themselves.
Okay, great, thanks. A couple more questions, Raj, for you. One came in, and could you mentioned the long waits for the community dermatologists. Can you speak a little bit to some of the reasons behind those long wait times for these patients?
Sure. So I think there are a couple of factors nationally for that. One is there's just a national shortage of dermatologists. There's, I think the American Academy of Dermatology is trying to increase the number of residency slots. A lot of that has to do with Medicare funding, but there's just a national shortage of dermatologists in general, that residents that are being board certified in dermatology, being trained in dermatology. Secondly, because cosmetic dermatology can be more lucrative and where you don't have to, there's not insurance billing and so forth, that a lot of dermatologists have focused more heavily on cosmetic dermatology, and because of that, there's a shortage of dermatologists who will see medical dermatology cases, skin cancer, eczema, psoriasis, severe acne, things like that. So I think, and thirdly, because dermatologists will have the ability to decide where they want to live, a lot of them have focused on more coastal areas or areas, so the rural parts of the country suffer from that because they don't have dermatologists who are residing in their communities. So it's a combination of a couple of different factors.
Great, thanks. Raj, you have another one. Can you talk a little bit about how your system disrupts reimbursement flows, and talk a little bit how that process works for providers and for telemedicine?
I'm sorry, for how it what?
Reimbursement flows. How your system disrupts reimbursement flows.
Sure. So so we contract with the insurance company directly, and we'll often, as part of that process, carve out a fee that clinics, and this is mandated through Medicaid, where clinics get a fee for the commitment and the time that the medical system and provider take to submit the case. So the clinic doesn't have to bill it all on our behalf. All their responsibility is to submit the case, and we bill the insurance company directly, and they get compensated for the time it takes to submit the case.
Okay, great. I think that's all the questions we have right now. Unless there's any other questions that are coming, these are great. It's nice to hear so many different types of questions. And actually we have one more coming in. Raj, I believe this is directed to you. Does the clinic see it as losing money? I assume we're talking about the telederm here?
Losing money, no, not at all. That has never come up. You know, a lot of clinics nowadays are on capitated contracts, and so you know, they're not. If we're helping them take care of their patients, not only is it about improvement in quality, but it leads to a reduction in the number of visits for that same medical problem. And so, with you know, I think as payment moves more out of quantity and more towards quality and efficiency, teledermatology can only help the primary clinic achieve those goals, and that's going to be both a quality improvement and a financial improvement for the clinic because of the way payers are now changing the way that they reimburse primary care physicians.
Great. Well, I'd like to thank all of our presenters today, Diane, Raj, and Shiva. Thanks so much for the informative presentations, and thanks to all the questions that came in today. It was great to get so many questions today. Thank you very much. If people could, before they sign off, we'd be willing, you should see the poll questions at the end. Just some feedback would be great. It should just take a couple minutes, not even. And again, thanks for calling, and hopefully you'll be joining us next month for our next webinar. Thank you.